Hello, everyone. Thank you for joining us today for our webinar entitled MACRA, MIPS, and APMs, Participating in the New Quality Payment Program. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, mceda.org. A copy of today's slides are available there now by going to www.mceda.org. Hover on the Resources tab and then select Webinars. Also, the presentation slides are currently available in the Handouts section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today we will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Bruce will take over and provide you with an overview of the new Quality Payment Program, followed by some information on what you can and should be doing right now to participate in 2017. Following the presentation, Bruce will take the time to answer any questions posed by the attendees. Housed within Alterum, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center, tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR incentive program. MCEDA's health IT services include the following. Number 1, meaningful use support at any stage and year. Providers participating in the Medicaid EHR incentive program also benefit greatly by qualifying for state subsidized services that bring our highly rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk assessment and network security evaluation. Risk assessment is an embedded service within our meaningful use support, but if providers only need assistance with the SRA, for example, to satisfy the requirements of the new Quality Payment Program, we offer it separately as a standalone service. The network security evaluation process is quick, simple, and with our tools and expertise, your technical security will be evaluated against known vulnerabilities. Contact us for more information. Number 3, attestation and audit preparation. If you are getting ready to attest and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for an audit and need assistance responding, we are here to help. Number 4, consulting services. With our broad range of consulting experience, we can provide hands-on performance improvement assistance with common pain points like patient flow, productivity, efficiency, and staff and patient satisfaction. Call today for a quote for services. Number 5, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives and preparing for upcoming advanced payment model changes under the new Quality Payment Program. Number 6, our Chronic Care Management Program enables physicians to take advantage of the recently updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. And number 7, funded by the Centers for Medicare and Medicaid Services, the Quality Payment Program Resource Center for the Midwest provides free help to clinicians in small practices and rural or underserved areas as they navigate participation in the CMS Quality Payment Program. Go to www.qppresourcecenter.com to join today. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining me today in what I believe will be the last time I present on this slide deck. I've been presenting on this one multiple times, countless times this year. As of January, we're going to flip over and start presenting on the 2018 rules. There are some significant changes, but since we're still in 2017, and I know there are a lot of questions and issues and problems and whatnot on 2017, we're going to go through this slide deck one last time before we start making 2018 changes. We've got a glossary of terms here. We like to talk in alphabet soup in the medical arena, so if I hit any acronyms that you are unfamiliar with, you might find them on this glossary. Okay, let's get into the bulk of the content. MACRA is the Medicare Access and CHIP Reauthorization Act of 2015. It's bipartisan legislation that actually can happen in today's administration. I bring that up because I know a lot of folks are hoping that this program might get blown up in the current administration. That is extremely unlikely to happen. It had tremendous support on both sides of the aisle. So we really aren't going to see MACRA go away, and nor would we really want it to, because it replaced the very flawed SGR formula that was going to cut very deep into the pockets of clinicians. This program then replaces the SGR. We'd have to bring something like the SGR back, and nobody wants that. MACRA is a lot more predictable than the SGR. It's going to increase the number of physicians that are participating in something called alternative payment models, and I'll talk about what those are briefly later on in this deck. It extends the funding for the CHIP program for an additional 2 years, and it introduces us to the Quality Payment Program. It's really part of this broader push towards paying for value and quality. Essentially, it's trying to get away from fee-for-service, where no matter how good or costly the care that's being provided for clinicians are getting paid the exact same. It starts to build some variation in there where physicians or clinicians that are providing high quality, low cost care can get reimbursed at a higher level for those services. There are some strategic goals embedded in the program, improving beneficiary outcomes, enhancing the clinician experience, increasing the adoption of something called advanced alternative payment models, or APMs, and I'll talk about what that distinction is, maximizing participation, improving data and information sharing, and ensuring the operational excellence in program implementation. Those are all great goals. I hope the program can achieve all of them. I draw your attention to the lower right-hand corner of your screen, that website there, the qpp.cms.gov. That I think is a resource-rich, very helpful website that the QP or that CMS has put together. I think between using that website and interfacing with us through our QPP Resource Center, you're really going to get all the information you need on this program. Conceptual MACRA diagram. This is as simple a diagram as I can pull together to kind of explain this, what is a fairly confusing program. At the very top, we have MACRA. It's an overarching legislation. There was a whole lot of things contained within MACRA that we are not going to discuss today, lots of regulatory changes. Then it gave us the Quality Payment Program, or QPP. Within the QPP, then, there are 2 paths that you can choose to participate in. You pick one or the other. Path 1, we're going to call the Merit-Based Incentive Payment System, or MIPS. Path 2, then, is the Alternative Payment Models, or APMs. Within alternative payment models, there are a few different types of APMs that are relevant to the program. We have something called advanced APMs, and that's kind of the gold standard. I'll talk about what those are. We have something called non-advanced APMs, or MIPS APMs is what they're referred to in this program. And really those non-advanced APMs or those MIPS APMs sort of bridge the gap between the two paths. So from a strict standpoint, we have the MIPS track and the advanced APM track are the two paths that you can take. And then that MIPS APM track is sort of in between. You kind of ride the fence. You're technically in an APM, but it's not an advanced APM. And so you still have to participate in the MIPS track. So there's a lot of clinicians that are out there in that boat where you're kind of bridging that gap and are still in some sort of alternative payment model, but it's a MIPS APM, and therefore you still have to participate in MIPS. So we're going to talk about path one, the MIPS path, MIPS track. The MIPS is the merit-based incentive payment system. It combines multiple Medicare Part B programs into a single program. It takes the Medicare EHR incentive program, and I want to pause here just for a moment, as I usually do when I get to this slide, and bring up the fact that this is not the Medicaid EHR incentive program. The Medicaid Meaningful Use program is alive and well. It runs in parallel to this program now. You have to, if you are participating in Medicaid Meaningful Use, it's not mandatory that you continue in that program. There's no penalties for not participating in Medicaid Meaningful Use, but there is significant incentive dollars to be had there. And so if you are eligible to participate in Medicaid Meaningful Use and you have not captured all 6 of the incentive payments under that program, you can still do so through 2021. At some point, the program will transition into stage 3. You have to attest separately in these programs. So attesting in MIPS does not do anything for you in Medicaid Meaningful Use, and vice versa. If you attest in Medicaid Meaningful Use, it does nothing for you in the MIPS program or the Quality Payment Program. 2 separate attestations, 2 separate programs. So continue on those Medicaid Meaningful Use path as well if you qualify and you've gotten in the door. So MIPS then takes the Medicare Meaningful Use program, which sunsetted in 2016. It now transitions into the MIPS program in 2017. We take the Physician Quality Reporting System, or PQRS, which has been around for 10 or 15 years. It takes that quality reporting program, and it takes the value-based payment modifier. We combine into these 4 performance categories of MIPS. So category 1, we've got quality, which is kind of the new name for what was the PQRS program and the quality side of the value modifier. We have the cost performance category, which is the cost side of the value modifier program. We have something called Advancing Care Information, or ACI, which is really just another name for what was formerly Medicare Meaningful Use. These same components of meaningful use are contained within ACI. It's just really the scoring that's different in this new program. And then we have a new 4th category called improvement activities. It is a new category, but the activities contained within it are most definitely not new. They were all based off of the patient-centered medical home model. So if you're a medical home, you look through that list of 94 activities that are available in 2017, and I'm pretty sure you're going to be able to find a number of activities you already have implemented. So while it's a new category, for most clinicians, the activities contained within are most definitely not new. So we take these programs and we kind of put them in a blender, and we get MIPS on the back end. So who's eligible for this program? In years 1 and 2, 2017 and 18, that is a defined list. We know exactly who qualifies. It's a very small list of provider types. You've got MDs and DOs, the physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. That's it. Those 6 provider types can participate this year and next year in the program. We do know that as of year 3, the door is going to be expanded significantly to broaden it and include many other provider types. We don't know yet exactly who this is going to expand to. We'll get that information sometime in 2018 through future rulemaking. This is a guess that CMS has included for us, but we know it's going to open up significantly as of the 2019 program year. We also have a terminology change in meaningful use and PQRS. We were referring to the participants as EPs, or eligible professionals. In this program now, they are called ECs, or eligible clinicians. So let's look at the other side. Who is exempt from the MIPS program? We've got a few different categories of providers that qualify for that exemption. They would not participate this year. So first year of Medicare Part B participation. So that looks at the calendar year that a clinician became a Medicare provider when they started to bill Medicare. If that happened in 2017 as a new clinician, you are off the hook for MIPS this calendar year. But next calendar year, you would have to be included. So whatever year you started to accept Medicare, you do not have to participate in MIPS that year. We have the low volume threshold. For this year, that threshold is 30,000 or really it's and provides care for 100 or fewer Medicare patients in 1 year. So how that works is both of those conditions have to be true in order to be a MIPS eligible clinician. You have to provide more than $30,000 in Medicare allowable billing charges, and you have to provide care for more than 100 Medicare patients in the measurement period. If either one of those conditions is not true for a provider, they are not eligible to participate in the program this year. You can still voluntarily report if you don't meet that, but your reimbursements will not be affected because you did not overcome that low volume threshold. So again, both of those criteria have to be true to get into the program. If either one of them is not true, you're not a MIPS provider. We do see that low volume threshold increasing significantly next year, but that is not till 2018. That has been finalized. We're going to see that bump up to 90,200 patients. So a significant increase. So what that's going to do, unfortunately, is cause a couple 100,000 providers across the country qualify, and they have to participate this year in the program, but then they will not qualify next year, unfortunately, because that low volume threshold goes up significantly. Third category of providers exempt then are those that are in that other path. Remember in that diagram we showed those two paths to the program. So anyone who is in the advanced alternative payment model path, they are exempt from the MIPS track. There's a couple of different ways that you can participate in the program as an individual or as a group. So as an individual, each NPI and tax ID number combination is seen as a separate entity in this program. So if you work at for multiple organizations, each one of those organizations will be reporting separately for you under the MIPS track. And what is done at another TIN does not affect the say TIN 1. So again, each NPI TIN combination is seen as a separate program entity. You can also participate at the group level. So any 2 or more clinicians who have reassigned their billing rights to a single tax ID can group report instead. So under that model, you'd be consolidating all of your data and sending one data set for all billing clinicians under that TIN to group report. If you are in an APM, which you may not know what that means at this point, when you see APM, for the most part, you can think ACO or medical home model. Those are really the main types of APMs we have, and really the vast majority of them are going to be those ACOs. If you're in an ACO, you are locked into group participation at the ACO level. So you don't get that choice to drop back into that individual reporting. If you're in an ACO, you are in that group. And if you group report, as I mentioned, you're going to be assessed across all of the performance categories that are used in that performance year. So when you participate in this program, what you're trying to build is the best MIPS final score you can. And that MIPS final score is it's a weighted across the 4 performance categories on a 0 to 100 point scale. So your goal then is to get the best MIPS final score you can, and you most definitely want that final score to be over whatever threshold, whatever minimum threshold is set each year. We're going to see that threshold change from year to year. In 2017, out of 100 points, it's a whopping 3. You need to score at least 3 points in this program in order to negate the payment penalty that is tied to this performance year, to this program year. The better that MIPS final score, the better chance you have of seeing an increase in your Medicare Part B reimbursement rates a couple years from now. So we see these 4 performance categories. They are weighted to build that MIPS final score. In 2017, which has been deemed a transition year in the program, we're only going to use 3 out of those 4 performance categories. You'll see for the most part, for most participants, this is how that 100 points shakes out. 60 points or 60% is going to come from quality. 25 points or 25% comes from the advancing care information. Again, that's formerly known as meaningful use. And then the other 15 points comes from the clinical practice improvement activities. We're not going to use the cost category this year. It is going to get used next year in 2018 at 10%. So next year we'll see quality drop to 50%, ACI and the improvement activities stay the same as they are on this slide now, and then we'll see resource use or cost used at 10%. And we will in future years see that increased significantly. By 2019, cost will be 30%, quality will be 30%. That is part of the legislation. That is a mandated piece. So we will see those weights balance out at 30 for cost, 30 for quality a couple of years from now. But this year, we are not going to use the cost category. As part of that, part of that transition year that we talked about, we also have the pick your pace option. CMS has given you a few different ways that you can participate this year. And if you need to or want to or have to, you can sort of ease your way into participating in this transition year. There's a few different ways to do that. Please don't pick option 1, which is don't participate. It's ridiculously easy to get to that next category. But if you do not participate, if you are a MIPS eligible provider, meaning you must participate to avoid that penalty, and you don't participate, you are going to get hit with a 4% payment adjustment in 2019. Don't do that. Please participate, because it's ridiculously easy to get to that next level, to that submit something, that test path. Under that submit something or test path, if you give CMS a single data point, that will negate the payment penalty. And the reason for that is just about anything you give to CMS is going to score. It's going to give you some points towards that MIPS final score. And with a threshold of 3 that you have to overcome, really anything you give to CMS is going to score at least 3 points, and likely even more. So a single data point is all you have to do. And what I mean by that is you can literally put 1 quality measure G-code on 1 claim for 1 patient sometime this calendar year, and that would be enough to get you that minimum score on that particular quality measure. The lowest score you can get on any quality measure is 3 points. So that alone is going to give you enough to get over that hump and into the test path. So you can do that with 1 quality measure, 1 improvement activity, 1 side of the ACI points. There's 2 different ways to score points under ACI. So if you do that just minimum amount, it's going to negate that payment penalty. At least do that. And from there, I would actually suggest trying to at least get to that submit a partial year. This is the time to test your system, test your workflows, test the program, and make sure that you can fully participate next year. Don't take the easy way out if you can do more. Use the gift CMS has given us with this pick your pace options to shoot for the moon. Try and do the best you can, knowing that if you fall short, you're at least going to be in that submit something, and it's going to negate that payment penalty this year. So shoot for at least partial year. So under partial year, you're submitting under from 1 to 3 performance categories for a minimum of 90 days. Submit for a full year is just that. You're fully participating, all categories, full year of data. You can realize the maximum financial potential of this program in either the partial submission or full. There's really the only difference between partial and full is the amount of data, meaning the more data you submit, if you participate in all 3 of the performance categories that we're using this year, you're going to get a better MIPS final score. You can manipulate that reporting periods or the reporting periods because they don't have to match between submission or between performance categories. You can submit data on anywhere from 90 to 365 days of data this year. You can maximize the financial potential at that 90-day mark as long as you're submitting across all 3 categories. You may or may not score better by extending to a full year. There's really no easy answer there. You just got to work the data, run the numbers. You can work with us through our QPP Resource Center and take, which will give you access to something called MIPS, which is a MIPS scoring predictor that we built, web-based tool. So you can start to manipulate that data and figure out what are those reporting periods between 90 and 365 that are going to net the clinician the best MIPS final score. Whatever that is, use that. A lot of different ways to get the data to CMS. The one it matters the most in is quality. I can't stress this enough. This is unfortunately one of the most important decisions that you need to make, is how you're going to route your quality data to CMS. Depending on the path you take to get that data there, it could net you a different quality score. I wish it wasn't the case, but I won't get too deep into it, but it all relates back to the benchmarks that are set. So for each quality measure, there is a benchmark. If you are above that benchmark, you're going to score well on the measure. If you're below that benchmark, which is essentially an average of those who have reported on it before, you're going to get a terrible score on the benchmark. Each submission method has a different benchmark. So depending that same score, depending on if you route it through your EHR vendor or a registry or a claims-based, could net a significant difference in that quality score. So on the front end of this, Liz mentioned the disclaimer that this presentation was as accurate as we knew it as of today. That actually isn't true. About an hour ago, we got some hot off the press news that kind of shakes this up. We just learned that something called the API for vendor submission is not ready, and it's not going to be ready. So CMS has been telling us all along that EHR through your EHR vendor is a means to submit that data. It turns out that system is not going to be ready. So I have been telling people all along, all year long, do not rely on EHR vendor submission. It has kind of scared me. I've been nervous since the beginning because this is new ground for the vendors, and I just haven't seen that the vendor community as a whole is prepared to submit data for you directly to CMS. It turns out CMS isn't ready either. The vendor submission API is not going to be an option for your 2017 data that you'd be submitting in 2018. You would still, the alternative there is that you will be able to log in to the new CMS attestation portal that isn't available yet, but is coming, and you'll be able to upload a file that you get from your vendor, but the vendor is not going to be able to submit that data, that file for you. Again, I just learned this at about 10 after 11 this morning, so new information. For some reason, they haven't even publicly put this out yet. There's information on the CMS website that is out of date. The only place we have found this is in a Google group that is there for the vendors. Again, just came across this information, but EHR direct from the EHR is not going to be an option. You'll still have to get that file from your vendor. Hopefully they can produce that file that they were supposed to be able to send for you. Turns out they can't. So you'll get that file, log into the CMS attestation portal. The clinician or whoever's doing their attestation for them will have to upload that file to CMS. The vendors will not be able to do it directly. So in terms of improvement activities and advancing care information, get the data however you can to CMS. Again, my guess is the attestation portal is going to be the most sure way to get that data to them, because you're in the driver's seat there. You can upload that data or manually attest to it. And it's also free. The vendors might charge you. Registries most definitely charge you for their services. The attestation portal will be free. If any of those submission options are unfamiliar to you, they're defined here. I'm not going to go through them. You can circle back. So what does it all mean? in terms of incentives and penalties. So just like in the legacy programs that this replaces, there's always a 2-year lag between the performance year and the payment year. So we're in the 2017 performance year. It is going to affect your 2019 reimbursements. The program is budget neutral. So the clinicians who are getting penalized are actually paying for those that are getting incentives or getting a bump in their reimbursements. It's a linear adjustment. What I mean by that is in the legacy programs like meaningful use, the penalty was the penalty and the incentive was the incentive. It was the same penalty for everyone and it was the same incentive for everyone. That is no longer the case. Depending on how your MIPS final score compares to the annual threshold that is set and will move, your reimbursement rates can be adjusted anywhere between the minimum and maximum rates that are set for that year. You definitely don't want to be in the bottom 25%. Everyone in the bottom quartile of attesters will automatically receive the maximum penalty for that program year or that payment year. It is 4% in year 1. We will see that increase to 9% as we get a little deeper into this program. Higher scores receive proportionally higher incentive payments. We won't see this year due to those pick your pace options that mean a lot of folks are not going to get penalized, although we won't have enough people getting penalized. But as we get a few years into this program, I think they will have to enact this what's called the 3 times modifier. I think CMS assumes there's going to be more folks getting penalized than there are getting incentivized. So to keep that budget neutrality, they've got the option of multiplying the top end reimbursement rate increase as many as 3 times over. So what was supposed to be a 4% gain maximum in 2017 could have been multiplied 3 times over to 12%. Again, we're not going to see that 3 times modifier used this year because CMS has made it so easy to avoid that penalty. But in future years, we'll see that. And then if you're in the top quartile, you want to be in that top 25%. If you're in that top 25%, you're in the exceptional performance bonus range. So this is where we step away from budget neutrality. Each year, there's an additional $500 million that is being set aside to reward these exceptional performers. So you want to get into that top 25%. CMS is estimating that top quartile will begin somewhere around the 70-point mark. So if you're trying to figure out, is my MIPS score good enough? If it's less than 70, I would say no. If it's over 70, you're in pretty good shape. So this is just a graphic that summarizes a lot we just talked about the incentives. We've got that performance threshold in the middle. We know this year it is a whopping 3 points. Next year it increases to 15 points. So you want to at least be over 3 this year and at least over 15 points next year. If you're below that, you're in the red and you're going to get penalized. Won't know exactly what that penalty will be unless you find yourself in the bottom 25% of attesters, in which case you'll get taken down to that maximum reduction. You'll see that it increases to 9% as of 2022. If you're above that performance threshold, you're in the green, and you should see a modest bump in your Medicare reimbursements. And if you're in that top quartile, you get to split up what could be an additional 10% bump in your reimbursements to divide up that additional $500 million. So we'll talk now briefly about the other side of the coin, that other path, the advanced APM path. So what are alternative payment models? It's a generic term that describes a payment model in which providers take responsibility for cost and quality performance and then have their payments adjusted based on that performance. So according to MACRA, there's several different types of APMs. We've got the Medicare Shared Savings Program, ACOs. Everybody, like 90% of the MSSP ACOs are Track 1 ACOs. Those are not advanced APMs, which I'll talk about in a moment. We have demonstrations under the Healthcare Quality Demonstration Program, the various CMS Innovation Center models that are active across the country, and then demonstrations required by federal law. So MACRA doesn't change how any particular APM pays for that medical care and rewards value. It's going to build on top of that. It adds in additional incentives So what I mean by that is every ACO has you've got some sort of shared savings agreement with that ACO. If the ACO performs well, high quality, low cost, there's some savings to be had that get divided amongst all the members. That doesn't change. Nothing changes with that contract you have with your ACO. This model builds on top of that, adds additional incentives in the form of a bulk incentive payment or a bonus payment. APM participants also participating in MIPS. If you remember, that references that middle ground, those MIPS APMs that I mentioned early on, where you kind of bridge the gap between those two paths. Those folks have to participate in MIPS, but because they're in a type of APM, particularly a MIPS APM, they're going to receive some favorable scoring. So if you find yourself bridging that gap, which many providers across Michigan most definitely do, then you're still getting some really good favorable scoring in the MIPS program in some of those performance categories. And then only some APMs are advanced APMs. That's that gold standard that really CMS is shooting for. We've got a few different types of APMs. I'm going to start from the bottom here. Those MIPS APMs makes up the vast majority of Medicare ACOs out there. All of the Medicare MSSP Track 1 ACOs are MIPS APMs. That's where you find yourself in that middle ground. You still have to participate in MIPS. You have to participate at the group level. You're participating at your ACO level in that, which what I mean by that is everybody in the ACO is going to receive the same MIPS final score based on the aggregation of all the clinicians in that ACO. So everybody consolidates into a single score under that ACO. So again, MIPS APMs make up the vast majority of the APMs out there. We've got qualified medical homes. Have a different risk structure, but are otherwise treated as advanced APMs. And then we have advanced APMs at the top. And really, the difference there is the amount of risk that's pushed back on the providers. If there's enough risk built into that alternative payment model, it can achieve that advanced APM status. There are not that many advanced APMs out there. I'll talk about what they are, but the incentives then for those advanced APMs, under model design, as I mentioned, that stays the same. They've got that shared savings, flexible payment bundles, whatever other desirable features are built into that contract. Those are not affected by the QPP. What you do get then for the next several years is the potential for a 5% lump sum bonus made right to the clinician if they're significantly participating in those APMs. So how that works is if you are a qualified participant in your advanced APM this calendar year, 2018 is the measurement year in terms of figuring out what that lump sum bonus is going to be. So whatever the clinician's Medicare Part B charges are for 2018, in early 2019, they will get an additional 5% lump sum bonus on top of whatever those 2018 payments were. You also get a higher reimbursement update. We're going to see the physician fee schedule lock in place after a year or two. It's not going to adjust year to year. The only way to get it to get a different reimbursement rate is to participate well positively in this program. As of 2026, we will start to see the physician fee schedule adjust again, but it's going to adjust at two different rates. For most folks, or those folks that are not in an advanced APM, it's going to go up at 0.25% per year. And for those in the advanced APM, it will go up at 0.75%. And as I mentioned early on, you're also exempt from the MIPS track if you are an advanced APM participant. There's not a lot of advanced APM options today, although we will see this list expand significantly over the coming years. We already know there are some other options coming live in 2018. But for the most part here in Michigan, we see providers in the CPC Plus program, which is really a medical home model that has enough risk built into it to achieve that advanced APM status. The Medicare Shared Savings Track 2 and Track 3 are advanced APMs. In 2018, we're also getting something called Track 1 Plus. I think a lot of the Track 1 ACOs, which again make up close to 90% of the Medicare ACOs out there, a lot of them are trying to become a Track 1 Plus ACO instead. again, by building additional risk into their model to achieve that advanced APM status. So you can check with your current Track 1 ACO to see how they're doing, or if they have plans to become a Track 1 Plus. And if you continue to participate, you'll find yourself in that advanced APM. We also have, I think, a couple of next generation ACO models here in Michigan as well. This list will be continually updated at the QPP website, so I can go there for more information on whatever the most current options are. So this kind of builds in the timeline overall. Well, again, as I mentioned, we'll see that fee schedule go up 0.5% here for a couple more years. As of 2020, it's not going to go up anymore. The only way to get it to adjust is to participate in this program. We see those two different reimbursement rates that when it does start to move again in 2026, depending on whether you're in an advanced APM or not. We've got that MIPS track in the middle. We've got our 4 performance categories. We see what that, what the top end and what the best reimbursement bump is, as well as what the penalty is on the downside. Starts at 4%, goes to 5%, and then we hit 9%, and that should go indefinitely. And then we have the APM track. If you're a qualifying APM participant in one of those advanced APMs, you get that 5% lump sum bonus, and you're excluded from the MIPS track. All right, so the rest of the time I want to spend going through 2017 MIPS participation. There's a lot of confusion out there trying to figure out all the different pain points and all the different decisions, questions to be had. I'm going to go through and hopefully provide some insight on what you should be working on today to ensure that you are ready to attest come 2018, early 2018, when the attestation window opens. I'm going to go through each one of these. I have a slide following this slide to go through each one of these, so I'm not going to read through these for you. So the first one is determining your eligibility. I get to figure out, first and foremost, are my clinicians, or do I even have to participate? There's different ways that you can go about it. The easiest way to go is if you grab that website down at the bottom, that last bullet, that www.qpp.cms.gov, just go there. You could try and figure it out yourself. If you happen to find the letter that CMS sent you back in April and May, that will provide you some information, but still not the level of information you need. Go to the qpp.cms.gov website. Right on the main landing page, right at the top, there is a link to get to their participation tool, their eligibility check tool. You can put in a clinician's individual NPI. I want to stress that group NPIs are not going to tell you anything. For the most part, group NPIs mean nothing in this program. It is all about the individual NPI and the tax ID number that individual is billing under. So don't put group NPIs in that at that tool. You're not going to get any data. So put in an individual NPI, and it's going to tell you whether that clinician must participate, and that's if it shows that they've overcome that low volume threshold at the individual level. It's also going to give you some information on whether they can optionally participate at the group level. The other bonus to going to this site is that you get the special status information. There's a lot of other decision points to be had. Is my provider hospital-based? Are they non-patient facing? There's some others in there too. So going to that site is going to give you the most accurate information you have. Choose to submit as an individual or as a group. A couple of months ago, I was telling everyone that this was one of the most important decisions to be made, and one of the most difficult decisions to be made. We continually get new information from CMS. This is one of them that really changed that. And it took, for a lot of folks, it took the guessing game or the guesswork out of this particular question, and I'll explain why. We have learned that if CMS gets a data set on an individual, so in an individual clinician at the NPI level, and they get a data set for that clinician at the group level, they're going to award that clinician with the higher of the two scores. So that kind of shakes things up a bit. If you can participate at the group level and at the individual level, you should participate both ways. So what that does is, if you participate at the group level, let's say you have an office of 5 clinicians. Mathematically, some of those clinicians are going to perform better than others. Mathematically, Half of them will be below the average, half of them will be above the average. So if you participate at the group level, your low performers will get a better score because their group score is going to raise them up because they get pulled up by the high performers. So at the group level, those lower performers do better. Then look at that group score and compare it against your individual clinician score. And for any individual clinician who scores better than the group average, you should also submit that data set to CMS. So what that does is CMS will then give that clinician, that high-performing clinician, their own individual score as opposed to the group score. So in that model, as long as you qualify, again, this only works if you are eligible to participate at the individual level. A lot of clinicians can only participate at the group level, but if you find yourself being able to choose between individual and group, do both. Do it at the group level because that's going to give your lower performing clinicians a little bit higher score because they ride on the coattails of your high performers, but then your high performers are not dragged down by your low performers, so that they will get their own higher individual score instead. So again, that only works if you are eligible to participate at the individual level. Choose your submission method and verify those capabilities. This is a tough one. The submission method, picking that submission method can be one of the most important decisions you make, especially in terms of quality reporting. It is not easy to figure out. You can work with us. There is technical assistance available to absolutely everybody for free. CMS is paying for a whole bunch of us, including this organization, to assist you with this. So the Quinn QIOs in Michigan, that is MPRO. If you are, that's for folks that are in large practices, meaning 16 or more billing clinicians under a single TIN, you can get free help from MPRO. The QPP SIRS and the TCPI are referencing some of the programs we have here at Altarum or MCEDA. You can get to us through that QPPresourcecenter.com. That's for, at least under QPP SIRS, that's for folks that have 15 or fewer clinicians. Again, free assistance. We can help you with that decision process, can help you figure out which submission method you're capable of doing, and if it's a viable option, and all the pain that comes behind that. But that's one of the most important decisions to be made, is how you're going to route your quality data to CMS. Prepare to participate. You got to consider that practice readiness. Have you participated in those quality reporting programs in the past? Again, that data submission method ties into your ability to report. Are you prepared to begin reporting data? That submission window is from January 1st of 2018 through March 31st of 2018. Review those pick your pace options and figure out what you're going to do. How are you going to participate this year? Again, as I mentioned already, I think everybody should shoot for partial or full year, knowing that if you come short, you've at least hit that test category and you've negated that payment penalty. So shoot for the moon, knowing that if you fall short, you're still okay. Choose your measures and activities. In terms of quality, again, this is a very difficult decision to be made, especially when you pair it against your submission options. This is kind of a disaster for you, and where you really, in my mind, should be spending the vast majority of your time in preparation is what quality measures are my clinicians going to report on, and how am I going to get that data to CMS? Most important decision to be made. Again, as I mentioned, the two websites between the CMS's website at qpp.cms.gov and our website at the QPP Resource Center are going to give you the wealth of information you need to help you with that decision process. You can click on that Explore Measures. There's a lot of great information there, as well as picking up the measure specifications off the QPP website. There's a wealth of information, but this is no easy task here. But again, there is free help to assist you with that decision. When you're choosing those measures and activities, consider the following. You want to look at your patient population, the clinical conditions you treat, your practice goals. Pick measures that are clinically relevant to your providers. You're going to score better. You don't want to pick a measure that you're scoring 0 out of 0 on unless you have to. Look for those measures that have good, solid data, that are clinically relevant, that just makes sense to report on. You can look at some of the legacy quality programs to consider what makes the most sense. There's something called a QRUR and PQRS feedback reports that you can get access to using your EIDM account to get some additional information. Verify the information you need to report successfully. It's not enough just to pick those quality measures. You really want to dive into those quality measures once you select them. We see a host of issues, both in terms of workflow, charting, a host of vendor issues. A lot of these quality measures are broken, unfortunately. So you run that report, you run your dashboard, and you get a numerator and denominator. Don't just assume that it's correct. I can't tell you how many times we have worked with clients to dive into those and have discovered that what appears to be poor quality in terms of that quality measure is not. It's really a technical issue that makes it appear as though the clinician is doing poorly in that quality measure. It could just be that an MA is not clicking the right radio button somewhere, or some structured data is not making it to the right space that quality measure is looking for. We see vendor issues where the quality measures are just not built right, or there's codes that are not linked in the background. So the quality measure is essentially broken. So it looks like poor quality when really you've got fantastic quality, and it's a technical issue that's causing that. So once you pick those quality measures, really dive into them. Look at that denominator to get who the patients are that measure is picking up. Then look at the numerator and figure out who's not in that denominator and find out why. It could very well be that some quick fixes and a little tweaks here and there could really drive a much better result on that quality measure. And I highly suggest going to the measure specification sheets for those quality measures, which you can download at the qpp.cms.gov site, or at least you can link to it to get to the resource library. It'll give you a wealth of information on each one of those. You can find out exactly what that quality measure is looking for. You're going to submit that data in the beginning of next year, the first 3 months of next year. CMS anticipates that window to open on January 1st. Again, there's a new attestation portal that's coming. If you participated in meaningful use, the Medicare meaningful use, you're familiar with the website you'd go to do that manual attestation. There's essentially a QPP version of that coming, so it'll work much the same. CMS told us it'll be a little bit easier to get into it, but you'll just manually attest there. If you are relying on somebody else to do that attestation for you, double check, make sure that it happened. We're all human. Every one of us makes mistakes. The person that you have farmed this out to is no different. They can make mistakes, and I'd really hate to see a clinician's reimbursement rate get affected and getting a 4% penalty just because somebody made an innocent mistake, thought they were doing the right thing, but just failed and didn't dot an I or cross a T somewhere and didn't get that attestation in. So seek that confirmation. Concluding thoughts, we're in the beginning stages of long overdue payment reform. Just like we saw in the meaningful use program, we're still getting a new definition of meaningful use from year to year, it seems like. We're going to see the same thing in the quality payment program. We've already seen what the 2018 version of the QPP is going to look like. There's some significant changes from 2017, and I have no doubt we'll again see a whole host of changes for 2019 as well. So it's going to continue to evolve. The long-term goal is to get everyone out of what I called track 1, that MIPS track, and get them into the advanced APM track. That CMS's long-term goal is to get more clinicians participating in the advanced APM track than in the MIPS track. We'll see it the other way for at least a few years, though, with most participants in the MIPS track initially. Significant bonuses and penalties here. As we get deeper into this program a few years from now, we could see as much as a 46% gap in reimbursement rates between the highest and lowest performers in this program. That is pretty significant. And also, don't forget about the current rules that are still in place. We're still, while the legacy programs that are now blended into the MIPS program have sunsetted, the performance years are done, the payment years still are not. So through the end of next year, you're still going to be hit with the penalties and hopefully bonuses of the value-based modifier, the Medicare Meaningful Use Program, and the PQRS program. So I know there's been a lot of confusion. The PQRS penalty letters for next year just came out a few weeks ago, and it's caused a lot of confusion because folks thought they weren't MIPS eligible, but and stuff like that. So just when you get those letters, think about the performance year that that's tied to. Those PQRS letters that some of you just got were for the 2016, that final year of PQRS, but it affects your 2018 reimbursements. There's always a 2-year lag. So we are coming into the final year of those legacy programs, the penalty year or the payment year of those legacy programs. Got some resources here for you, the top 2 being the most important ones. You should be able to get all the rest of the information. There's some other great links here as well, including to the massive final rule for the QPP that was like 3,200 pages. And with that, I'm going to switch to questions. I've seen quite a few questions come in as I've been speaking. If you have a question for me, please send it through the questions function of your GoToWebinar interface, and I'll answer as many as I can. Some of you might stump me. If I skip your question, it means I'm going to have to do some research. I want to answer intelligently, and I want to misinform anybody. So I might skip over some. I'll get to as many as I can in the time I have left. Okay. So the first question, on slide 15, you talk about the 2 dates. Let me get over to 15 here. So on slide 15, you talk about the 2 dates. Will CMS look at both dates, and if you qualify at one, you are in, or do you have to qualify for both dates? And will QPP update their QPP website? If they are, do you know when? Lots of questions embedded there. So thank you for asking that one. So the way this works, this is referencing the light blue dates used for 2017. So in phase 1, they took September 1st of 2015 to August 31st of 2016 to gauge a clinician's eligibility. If they determined that you are MIPS eligible during that phase 1, that eligibility stays in place. It doesn't matter what happens in phase 2. In fact, I don't think that clinician even really gets reassessed under phase 2. So if you're in, you're in. So if they've deemed you MIPS eligible in phase 1, that does not change. You are MIPS eligible. Phase 2 is used, they did a second look a year later, really for any clinician that they could not assess in phase 1. So if they were a new clinician or just wasn't enough data on that clinician to determine their eligibility during phase 1, they did a second check under phase 2 and to determine whether that clinician is either exempt from the program or MIPS eligible. So again, phase 2 is only used if they could not assess the clinician on phase 1. If they were able to assess on phase 1, that does not change. To get deeper, the other part of that was, are they going to update the QPP website? As far as I know, yes. I've got no indication as of yet whether that participation tool already has the phase 2 data in it. That stopped as of August 31st, 2017. So I certainly hope by now in December, they've been able to build that, the phase 2 data in. So really, at this point, if you go to that eligibility tool, I think you can assume that it's correct. If it's got that data in there telling you you're either exempt or MIPS eligible, go with that information. Next question. If you're a provider who is not eligible as an individual, but you are eligible as a group, are you eligible to submit something as per your slide, i.e. one measure? You could, but it wouldn't buy you anything. So if you are exempt at the individual level, that's it. You're not going to get penalized. Even if you are eligible to participate at the group level, that is not mandatory. You are not forced into group participation. Group participation is an option for you. So if you are exempt at the individual level, you can band together and participate as a group. But if you do not, then you're not going to get hit with that penalty. But if you do opt in at the group level, really, there's not much, you're not going to get hit with that penalty. Because again, anything that you submit is going to get you over the 3 points. So in a sense, yes, you can be in that submit something bucket, but group participation is not mandatory. Only individual level participation is. So if you find yourself individually exempt, but optionally eligible at the group level, you could certainly, I encourage you to participate at the group level, but really anything you submit to CMS is going to give you at least 3 points. And again, even if you didn't submit anything, only those clinicians that are eligible at the individual level are the ones that are going to get hit with that penalty. So there's really no danger there. Under slide 20, what if our registry, let's bump to slide 20 here. What if our registry submits data and our EHR submits data? Which is going to happen? Which is going to happen for us? What will CMS use? Well, you probably, And then the next question, the same submitter says, "What the heck? What do you mean EHR will not be ready? What are we going to do?" So the question is, what if CMS gets 2 data sets? If they get registry data and they get EHR data, so 2 data sets on a single clinician. If that happens, CMS is going to score the clinician whichever one is better, whichever one is more favorable. So you can submit multiple data sets. CMS will ignore all but the best one. So to get to the second question, what are we going to do? If you were counting on your EHR vendor being able to submit that data directly for you on your behalf, directly from the vendor to CMS, as I mentioned, that is not going to happen. We just learned within not even an hour before I started this broadcast that the vendor submission API is not going to be ready. So what you will do instead is work with your vendor to get the file that they were going to be submitting on your behalf. They should be able to transmit that file to you. You will take that file, go to the CMS attestation portal and upload it yourself. So again, if you did that as well as submitted data through a registry, CMS is going to score that clinician with whichever one is more favorable. Will we lose the 6 points for the EHR to CMS submission for the quality since the vendors cannot do this anymore? No, I think you're okay there. So that's a great question. This is referencing the bonus points that are available under the quality category for what's called end-to-end data submission. So you can earn bonus points under the quality category if the submission method you choose is deemed an end-to-end electronic submission, meaning there's no manual data entry. So claims-based reporting does not qualify for those bonus points, but EHR vendor submission would have, because it's electronic, it's going right from the vendor to CMS. You can still qualify for that with manually uploading that file. So the difference there is you're not manipulating that data. You're taking a data file directly from your vendor and submitting that to CMS. CMS still deems that end-to-end electronic. It's just that you're not going in and typing in numerators and denominators. So that would not work. So yes, as long as you're uploading a file from your vendor to CMS, that would still qualify for those bonus points. Great question. We have found that the QPP webpage is not accurate. Hospital-based, whether they qualify or not, is that the gospel truth? In other words, if we know they qualify, but QPP says they do not, can we assume they are exempt? Unfortunately, yeah. I know we've seen a lot of issues where the data that appears there is incorrect. That participation tool has really brought to light a whole host of billing issues. But yeah, whatever it says in that participation tool is the same data CMS is going to use. You can work to figure out what's wrong and get that corrected. I don't know that CMS is going to change any sort of determination that's made for 2017, but at least it'll get you cleaned up for future years of the program. But yeah, I would say whatever's on the QPP website is the gospel truth, and go with that. What measures will be reported as a group by my ACO? What measures will be reported as a participant in CPC Plus Track 2? What measure do we need to report as an individual EC? Great questions. So the ACOs, they are locked into 15 different measures. So the ACOs use they use what's called the CMS web interface to do their quality reporting. So how that works is in early 2018, your ACO is going to get a list of patients, a subset of each clinician's patients that are in the ACO. The ACO then comes to the EHR, gets access to the EHR, and does some data extraction against 15 specific measures. And so each one of those patients is essentially scored against those 15 measures, and that then goes into the quality score for that ACO. What measures will be reported as a participant in CPC Plus Track 2? So I'm not going to get into CPC Plus as a different program. I want to focus strictly on the QPP. Technically, CPC Plus is an advanced APM, so you're exempt from the MIPS track. So you just have to work with those program requirements, and I don't want to get into CPC Plus rules here, nor am I today that qualified to do so. What measures do we need to report as an individual EC? Really, you can pick, as an individual, you can pick there are 271 measures available for an individual to report on this year, which is an overwhelming amount to go through. So work with us, work with the CMS QPP website to try and narrow that down. You can look at specialty measure sets to help narrow that down. We can help you through that measure selection, working with us as well. So sign up for the QPP Resource Center. But that's no easy task to figure out. But again, any clinician can report on as an individual on any of the 271 that are available. Is there a place where I can review this information? Absolutely. You can get the slides. If you look in the handouts portion of your GoToWebinar interface, there's 2 versions of today's slides there for you to review. Again, work with us through the QPP Resource Center, and we can really help you, can guide you, and provide some insight in how to prepare and how to participate in the program this year. Next question. Under the group attestation option, providers can attest using administrative claims. How is an administrative claim different from a regular claim? There's not a whole lot of difference there. It's really, administrative claims are just claims at the group level. They calculate it a little bit different at the group level versus the individual level, but essentially you're not really doing anything different. Claims-based reporting is CMS taking all of the claims on all the clinicians, whether you're at the group level or individual level, and scoring them appropriately. So functionally, there's really not much difference between an administrative claim or a regular claim. Good question. I asked that one myself about a year ago. Have you received any data on how we will attest through QPP? Not really. We know that there's an attestation portal coming, but that's really all we know. I don't know when it's going to be released. We'll see it certainly by the first of the year, but there's certainly more to come on how we're going to get access to that. CMS has told us they've made it a little bit easier to get in than the meaningful use one, but to me that just remains to be seen. I already mentioned where you can find the slides. Again, you can pick them up right now out of the handouts section of the GoToWebinar interface. You can also go to the mceta.org website and download them there. If you hover over the resources tab at the top and then scroll down to webinars, you can get access to these slides and really every slide I've done for the past 4 years, every webinar I've done. If group reporting, do we report on providers who were with us during part of 2017, but also left during the 2017 year? That depends on your reporting period. So if your reporting period, and again, that can be anywhere from 90 to 365 days. If that reporting period that you choose includes when those clinicians were with you, then yeah, you have to include that data. But if you're picking a period outside of when they were working with you, then obviously you wouldn't be including that data. So it all depends on that reporting period that you picked. If they were working with you during those days, then yes, you need to report on them as well. I am confused about the 3-point minimum. If you meet this, can you still get hit with a penalty if in the lower 25%? Fantastic question. I'm glad somebody asked that. No. The answer is no. If you hit that 3-point, if your MIPS final score is at least 3 points, you will most definitely not get hit with a payment penalty, even if 3 points is in the bottom quartile. So great question, very astute. So as long as you get that 3-point minimum, you absolutely will not get hit with a penalty. Don't worry about that bottom quartile. Do I have to submit the quality measures through a file from the vendor, or would it be similar to Meaningful website where we submitted data through numerator denominator numbers? So you cannot manually attest quality measures. You will not have the option to type in numerators and denominators. So no, you most definitely do not plan on that. So under meaningful use, even if you're in the Medicaid side, if you're in the Medicare side, you could just type in those numerators and denominators for your quality measures. That is not an option under this program. You cannot do that. There is no manual data entry option available for your quality measures. For the others, for meaningful use or ACI and for improvement activities, yes, you're going to type in numerators and denominators, or you can type in numerators and denominators in the QPP website. The only way to submit your quality data through the coming QPP attestation portal is by getting that file from your vendor. It can only be through that file upload. That's your only option to get that data through the attestation website to CMS. Good question. If not on an EMR, the only way to submit data is on the claims with the G code. That's a question. Where do we find the corresponding G codes? Good question. So yeah, if you do not yet have a certified EHR, you're not going to be able to do anything but claims-based reporting for the quality category. Each of those quality measures that can be reported via claims has a particular G code that you have to put on that claim. To figure out the specifications, what those codes are, you have to download. The best way is to go to the QPP website and get the specification sheet for that quality measure. There's probably there's 7 pages of information on all 271 of these measures. So go to that. It really breaks down to minute level all the data around that quality measure. So go to the measures specification sheet and you can figure out what that G code is. Can you explain numerator versus denominator? Certainly. So in each one of these measures, the denominator is the number of patients who could have had that measure applied to them. Let's look at NQF 59, which is the diabetes A1C control measure. So the denominator there is all the diabetic patients, any patient in the clinician's practice that is carrying a diagnosis of diabetes. Then the numerator looks at their outcomes. It looks at their A1C level, and anyone who has their A1C controlled at around better than 9%, would appear in that numerator. So the whole patient population, for whatever that measure is looking at, would be your denominator, and then the numerator is how many of those patients had X done to them. And again, there's no way to generalize there, because each one of those quality measures, the numerator definition is different. So denominator is everyone who could have met the measure, and then the numerator is any of those in the denominator that did meet it. We have been approved for the test phase of MIPS. Is that for next year? And that is the info we start submitting in January or before January. We want to break even in 2019. So there's no approval for the test phase of MIPS. I'm not sure what that means. If you are deemed a MIPS clinician at the individual level, you have to participate in MIPS to avoid that penalty. That test option is one way to negate that payment penalty that applies to only the 2017 program year. We do not have these test options next year for 2018, but again, that's for the performance year, 2017. The attestation window is early 2018, so that's when you'd be giving CMS that little bit of data if you're going to just opt for that test option. But then you can go beyond that too. So there's no approval for the test. Anybody who's a MIPS eligible clinician is approved for that test option. You could do that one data point to negate that payment penalty. So if you want to break even in 2019, if you don't want to be assessed that payment penalty in 2019, you want to at least submit a single point of data to CMS. It's for 2017, but you'd be doing it in early 2018. I know we're crossing all these years, it makes it kind of confusing. I hope that cleared up for you. If you submit data with a registry, does something have to be sent on a claim also? No. If you're doing registry reporting, then you're not putting those G codes on the claims. If you're putting those G codes on your claims, that's telling CMS that you intend to claims-based report. So yeah, those G codes on the claims are only relevant for claims-based reporting, not registry. Got a couple more questions. I know I'm a couple minutes over, but I'm going to stay on, see if I can get through these last ones here. It seems that I missed the presentation, and I wonder when it will be available online. We typically have the recordings uploaded within a few days. So today is what, Tuesday? Check by Thursday or Friday on our website. We should have it up then. And again, you can grab the slides at any time as well from the website or from right now from your GoToWebinar interface. I think this one, yeah, I already answered that one. It was again asking about registry-based reporting and if you also have to submit something on a claim that, so you do not. I think I already answered that for you, Patty. Last year, I submitted the PQRS and the meaningful use on the same time, but for some reason, Medicare received MU, but not PQRS. That wouldn't have been at the same time. Those were, if you participated in PQRS and in meaningful use last year, those would have been two separate attestations. There was no two birds, one stone there. It could have been, if you're speaking specifically about the quality data, there was a two birds, one stone there where you could have opted in through the CMS web interface. If you submitted there, you could have gotten credit under meaningful use by participating in PQRS, but that was a very specific workflow and a very specific data submission that you would have had to do. If you did follow that and something happened, I would work with CMS to figure out where their mistake was there. Sue was saying, I did send them separately. but for some reason, Medicare received MU, but not PQRS. So yeah, if you have proof that you submitted your PQRS information and you're still getting hit with that penalty, I would opt to be reviewed. I would have CMS take a look at that and see if you can get the penalty for PQRS reversed. Again, if you have that proof that they received your PQRS data, then hopefully you can get that reversed. Okay, folks, that is it. I don't have any other questions, and I'm sort of out of time. If you have any additional questions, comments, concerns for me, let me bump to my email address at the end here. Went too far. You can reach me at any time. Let me see if I can get that back up for you. Not going to let me. Okay, so go to the QPP Resource Center, and you can get to me there. You can also go to cms.org, and you can get to me there. A lot of you have my email address because I hear from you on a regular basis. My phone rings off the hook as well. Certainly, you can reach me in multiple ways. I'm happy to answer additional questions. It is what we are here for. Thank you all for attending today. I look forward to seeing you again next year when I kind of change this slide deck up and start talking about 2018 participation. Until then, thank you all.